I think, shall we start?
Yes, sir. Few people are having some technical issues, it seems. I think they will be joining soon. Then start, sir.
Oh, okay. Yeah, no, I know. I had said we'll do ventilator as a pulmonary function lab, and then I realized that we haven't done some basics first, and trainees are at all levels. So I thought we'll do some basics, which will include part of pulmonary function lab, but a pulmonary function lab as ventilator as a pulmonary function lab talk can be done later. So,
Sure, sir.
Is everybody else able to hear? I don't get any response.
No, sir. It's audible, sir. It's audible and your screen is visible too.
Fabulous. Okay. So I don't have any conflicts of interest. Some of the slides I'll show is from my mentors, Dr. Brian Kavanagh and Laurent Brachard. This is a slide that Brian would use to teach us how mechanical ventilation is related to ICU actually originated or developed. Because we're in the middle of pandemic, it is pandemics that have pushed us to create critical care medicine, to be honest. This was the last massive pandemic of polio back in 1950s. And this is the scientist, Bijan Ibsen, who wrote this paper back in 1952. What he was essentially doing is that, children with poliomyelitis were dying. And some of times they were put into a negative pressure ventilator. And despite that, they would die. And often they would be measuring bicarbonates and renal functions, and the stuff would be thought that there is acidosis developing, and it is because of the kidney failure. And what they're dying is eventually from something like a multi-organ dysfunction. The terms were not as clear at that time. Bijan said this is not true. What they're dying is because of respiratory failure despite being on the ventilator. It's because a lot of secretions are clogging their airways. And this bicarbonate changes that you see in acidosis is largely a reflection of respiratory acidosis, not purely metabolic. Initially, it is respiratory. Nobody believed him, but he said, okay, why don't we trach a couple of patients? It was not very hard to do so. They would trach, and they needed a lot of good suctioning with a negative pressure, remove a bunch of stuff, and then bag those patients. And they started living. This is a place where it was done in this small room. This is where positive pressure ventilation for acute respiratory disease in a mass scale started. Elevated bigas and persistent hypoventilation. And if the negative pressure ventilation is ineffective, then positive pressure is life-saving, is what he said. What he did is, what oftentimes we do in India in rural settings, if you've worked in underprivileged situations, where I have, that approximately 200 medical students were asked to manually ventilate patients via tracheostomy. There's no ventilators the way we know them today. And the overall mortality reduced to 25% compared to an anticipated rate of 90% at that time. This was fabulous, isn't it? So tracheostomize them and manually ventilate them. They would probably rotate, the medical students would rotate, and children started surviving. So this is where mechanical ventilation now. Before that, there was positive pressure ventilation in the form of CPAP only for surgical procedures. It was more of anesthesia. Bijan Ibsen is an anesthesiologist. This is in Copenhagen. So after this, we started thinking, okay, maybe positive pressure ventilation can be used in acute respiratory conditions and can be brought into more, continuous management, like days after days, not just for a few hours of surgery. This was a search that I did just about a year ago in PubMed, and the number of results mechanical ventilation shows is profound. In the current pandemic, we know that ventilation shortage is causing some amount of attributable mortality. Some amount of mortality is attributed to ventilation shortage in some portions of the world, and we're talking about ventilation sharing and stuff. So it certainly means that we need to know the ventilator better, and the critical care physicians need to be respected more. What do we need to know? We need to know so many things about the ventilator, right? The basic ventilator design, the ventilation cycle, the basic modes, what the variables are, and then we need to know the respiratory system. This is about the ventilator, and then it's about the respiratory system, which is compliances, specific circuit compliance, what is auto PEEP, and what is airway closure. So we need to have an idea of what the respiratory physiology is and what the ventilator is. Two things. Central to getting both of these combined is the equation of motion. That is where we will go today. Now here is a small schematic diagram of what a ventilator design looks like. Now you certainly have used a lot of ventilators, and some of you might have used a little older ventilator. If you have a, when I worked in India, we would overnight, if you had a problem with Siemens 300 or 900, we would open the back, check the flow, manually fix it. Now the ventilators are sophisticated where you don't get to do all that. But fundamentally, there is a blending area where air and oxygen blend. Then there is a gas delivery system where how the gas will get delivered is figured out. It has certain components. Then there is a valving system, which will, it's a two sets of valves, inspiratory and expiratory valve, and depending on the time and the flow, how the cycling between inspiration and expiration, the valves will work to open the inspiratory valve or close the inspiratory valve, and like that. And then finally, it is the delivery to the patient. I won't go into the details of this, but basic schematic understanding is important. Now, this is very important. From here on, we talk about how we move from spontaneous breathing cycle without the ventilator to positive pressure ventilator in a couple of modes, and go very simple and very basic. This is more to engage trainees and to have your understanding better on the subject. So stop me anytime you need to look at a particular slide a little longer. It should be fine. Now, if we look at spontaneous breathing, and if you are able to measure tidal volume, which is this one, and flow, then naturally we are kind of pressure controlled breathers. We generate a negative pressure and the volume comes in. We don't fix the tidal volume in our brain or anywhere. The brain sends an electrical signal to the diaphragm, which is what kind of determines the pressure. Usually for every 1 millivolt, you will get 1 centimeter of water kind of stuff. So this is the pink line here is the muscle pressure. As the muscle pressure becomes negative, which is it drops below 0, it is -5, you create a pressure gradient. This pressure gradient will increase the flow, right? Because there is a pressure drop in the alveoli. The yellow, the blue line is the alveolar pressure. As the muscle pulls down and it becomes negative, the pleural pressure becomes negative. The alveolar pressure initially becomes negative. Because the alveolar pressure becomes negative to the atmospheric pressure, there is a pressure gradient which is more towards the outside and less towards the inside. This generates a flow, which is the inspiratory flow. And that eventually delivers a tidal volume. In an adult, that would be somewhere around 500 ml for a negative pressure just of 5 centimeters of water. As now during expiration, so this is an alveolar pressure which is negative, but the alveolar volume is positive, of course. Tidal volume is always positive. And as you breathe out, the pressure in the alveolus increases. The muscle pressure comes back to 0. It never becomes more positive, little bit, but not significantly. Whereas the alveolar pressure becomes significantly positive relative to the atmospheric pressure. As the muscle relaxes, because alveoli has gas in it, now as the muscle relaxes, the gas inside the alveoli exerts a pressure and the alveolar pressure increases. This increased alveolar pressure in relation to the atmospheric pressure, which is 0, creates an opposite flow, and you get an expiratory flow, and the tidal volume is breathed. You breathe out the tidal volume. If you increase the muscle pressure, that is breathe harder, the whole cycle is more intense. You have more drop in the alveolar pressure, you have higher flow, and you have more tidal volume delivered. This is keeping the inspiratory time same. right? The inspiratory time is same. Here is the peak muscle pressure, then muscle pressure is still constant here. So you're continuing to have a breathe in, and then you relax, and then you breathe out. So for the same time constant of breathing, or neural time, neural eye time, so that is an inspiratory time which your brain fixes, the same neural eye time, if the negative pressure increases, the tidal volume will increase. Simple. The flow will increase and the tidal volume will increase. Now, if you change the neural time, in the sense breathe a little longer with the same negative pressure, that means the negative pressure hasn't changed much, then no matter what, how longer you breathe, the tidal volume will be the same. This is important. It will stay in the lung longer. That will of course eventually give you a little bit different kind of gas exchange availability. But if you breathe for the at the same depth for a little longer, it does not mean the tidal volume will be higher. The tidal volume will be same. This is because volume is determined by the pressure, not the time for which the pressure stays. Right? So the negative difference in the pressure, which is this will give us the same amount of flow, will give us the same amount of tidal volume. So far so clear? Hello?
Yes, we understand.
Okay, good. Everybody's here. Now let's go to positive pressure ventilation in the volume control cycle. Why do I choose volume control cycle? It's not because this is the right thing to do or wrong thing to do. It is an easier mode to understand various aspects of what we just said earlier. Here is a complete passive ventilation, means no spontaneous effort. As we said, this is a muscle pressure, which is 0 now. You cannot see muscle pressure anywhere. And this is alveolar pressure. What do you set in volume control mode? You set a tidal volume or you set a flow. For a similar tidal volume as spontaneous breathing, or for a similar inspiratory flow, you will require a lot more positive pressure. We can see here that as the flow increases from 0 to kind of 60, it will stay at 60 for the defined period of I time. This is determined by the amount of flow you've set. Flow is liters per minute, so it is volume upon time. So if you set a tidal volume of 500 and you've set a flow of 60, then I time is naturally determined. You're not setting it up an I time, but you're basically selecting a particular I time. So if you want to change the I time for the same tidal volume, what you need to do is change the flow. In this schematic, as you see, for the same tidal volume, what we need to do to increase I time is lower the flow. If you set the flow lower, here it was 60, here is kind of 25, and then it is even longer. Every time you keep prolonging the flow, the I time increases. So if every time you lower the flow, the I time gets prolonged. Lower the flow, more is the I time for the same tidal volume. Higher the flow for the same tidal volume, shorter is the I time. Now, why is that important? Now let's concentrate back on this part. As you see that, you increase the flow, you get a delivery of tidal volume, the airway pressure will increase to a particular value. And once the flow is static, which is it has achieved its maximum limit, the pressure will continue to increase, but the slope of the pressure has become less. It's not absolutely straight increase in pressure. And then when the flow starts to come down, which is you start breathing out, here is the expiration, and the pressure drops back to baseline pressure, and that's how you cycle. The pressure is being determined in a volume control cycle. It is not being set. How is it determined? A, it is determined on the condition of the lung, and B, it is determined by the way you have set up the ventilator. Here we're not talking about the condition of the lung. The condition of the lung is the same in all three examples. But you will see that as you change the flow, the peak airway pressure keeps reducing. I'll come to that in a minute. Before that, as you increase your tidal volume with your increase in flow, the alveolar pressure also increases. Alveolar pressure is the pressure that is measured inside the alveoli. This is a hypothetical diagram here, but what it wants to say is that alveolar pressure will follow the tidal volume curve. That makes sense because the pressure in the alveoli determines the tidal volume or the volume inside the alveoli. The tidal volume, of course, has two parts: alveolar volume and a total dead space volume as well. But we assume that this is a normal patient. The dead space is physiologic, so most of the tidal volume is determined by the alveolar pressure, or in volume control we can say it the other way: the tidal volume determines the alveolar pressure. But in this first example here, the alveolar pressure and the peak airway pressure are far apart. And as you slow the flow, that means as you keep decreasing the flow, the peak airway pressure and the alveolar pressure keep coming closer. You see what I mean? So if you stop the flow at a particular time, then the peak airway pressure at that point with zero flow will be equal to the alveolar pressure. That is what we measure on the ventilator as a plateau pressure. Now, why does this happen? This happens because when you set up a volume control ventilation, you give a flow, there is an initial increase in pressure because this flow, the atmospheric pressure is zero, and the pressure at the beginning of inspiration is also zero inside the alveoli. There is no gradient. As you start giving the flow, the positive pressure builds up in the system. Once the flow achieves its maximum and it stays there, further buildup of the pressure is slower because the gradient of the flow is now zero. As the gradient of the flow increases, the pressure increases, and then with further continuous flow inside, but at the same constant level, the pressure slope decreases, but the pressure continues to increase. Once the inspiratory flow stops, the pressure will decrease. The system gets decompressed. The pressure in the alveoli is, in the respiratory system is higher than the atmospheric pressure, and the flow reverses, and there is expiration. As you decrease the flow, the pressurization will also decrease, because when you're giving a flow from 0 to 50 versus 0 to 25, the pressurization is slower and lesser in 0 to 25 compared to 0 to 50. This makes sense. Which would mean that the ability to equilibrate between the airway and the alveoli comes closer as the flow becomes lesser and lesser. Does this make sense? Very good. So the reason I say this is because this is not about how to set the ventilator. This is about how the ventilator actually functions and why we say that plateau pressure is equal to alveolar pressure, or end expiratory hold when we do auto PEEP measurement. Why do we see that this is the alveolar pressure at the end of expiration? That is because when there is no flow, the pressure in the airway reflects the pressure in the alveoli. I'll come to that again in a minute. All right. And you see in this example, because the tidal volume is same, it is for a longer period with the flow decrease. The alveolar pressure is actually the same. This is to give you an idea that the way you set the ventilator will determine the difference between the peak airway pressure and the alveolar pressure. Which is to say, higher the flow, more is the difference between peak alveolar pressure and the peak airway pressure and the alveolar pressure. This difference is the resistive pressure. We'll come to that in the equation of motion, but just for in this slide to note that the way you set the ventilator will determine the difference between the peak, or the way you set the flow, or more correctly, lower the flow and volume control, closer is the peak airway pressure to the alveolar pressure. Okay, this is an important thing just to remember in this slide. Now, in that we change the flow, that is, we keep decreasing the flow. In this example, we do not change the flow, but we increase the tidal volume. So if you increase the tidal volume or decrease the tidal volume, in this first example, you increase the tidal volume, keep the flow same, then to deliver the higher amount of tidal volume with the same flow, more time will be required. This will increase the I time. And when you decrease the tidal volume with the same flow, less I time is required. You see this? However, the slope of the resistive pressure, which is during peak flow, does not change in this condition. This is because the flow has not changed. The peak flow has not changed. So if you keep the flow same and you increase the tidal volume, you will increase the overall pressure. That means will increase the alveolar pressure and proportionately increase the airway pressure. And this is an important thing on this slide. All right, that the slope of this pressure, which is the resistive pressure part, depends solely on the flow. And why is that? This is the reason. Here is the reason. So this is a very important equation which one needs to remember for mechanical ventilation, and it's called as equation of motion of the respiratory system. In controlled mechanical ventilation, the total pressure in the airway is P0. This is a muscle pressure. So if you have spontaneous breathing along with mechanical ventilation, then there is an addition of this pressure as well. But we'll say the patient is paralyzed, or right now we have attached it to a test lung or a mannequin. So this part is 0. So let's forget that, making it simple. So the airway pressure is determined by two sets of pressures. One pressure is flow multiplied by the resistance of the respiratory system, and other pressure is the elastance of the respiratory system multiplied by volume. What does this mean? This is the resistive pressure, this is the elastic pressure. The pressure that the ventilator needs to travel the gas from the endotracheal tube through the airways is the resistive pressure, is the pressure required to overcome airway resistance. Now this pressure is determined by two things. A, on the respiratory system, it is the resistance of the airways, but it also is determined by the flow set by the patient, by the physician or the clinician at the bedside. So higher the flow you set, more is going to be the resistive pressure, even if the respiratory system resistance is the same. And for the same flow, if the respiratory system resistance increases, the pressure for the resistive pressure will increase. The second part of the pressure is the elastic pressure, which is what the alveolar pressure is, which is from the peak to the alveolar pressure difference, or peak to the plateau difference, as we said, we will see the plateau here again, is the resistive pressure. But from the plateau down to the baseline pressure, or the alveolar pressure, in this example, as you see from this spot to this spot, is the elastic pressure. Now, what is that elastic pressure? The elastic pressure is also determined by two things. A, the elastance of the respiratory system, which is the inverse of compliance. That means how deformable the lung is, the parenchyma beyond the airways. More easily deformable, that means less is the elastance, high is the elastance, less is the compliance, in which case the pressure requirement will be low. If the elastance increases or the compliance decreases, that means the lung is not easily deformable, then the airway pressure required to overcome that is going to be higher, or more pressure will be required. Similarly, the elastic pressure is also determined by the tidal volume set on the ventilator. So A is the lung condition and B is the way you set it also determines this pressure. This is very important to understand as crux that what we measure at the airway pressure on the ventilator has two components on both sides. Like there are two components, one is resistive pressure and elastic pressure, and each of this component has a contribution from the way you set the ventilator, flow in the case of resistance and volume in the case of elastance, and has a contribution from the nature of the lung, that is how much is the resistance offered by the airways and how much is the elastic recoil of the lung, or elastance of the lung, to be honest. So if we remove the flow, as we said in the previous example, that if you keep getting the flow out, that means there is no flow in the ventilator, then actually by this equation the resistive pressure goes out, because in the absence of flow, even if it does not mean that airway resistance disappears, the pressure for the airway resistance will disappear, because since there is no flow, there is no gradient, so this pressure becomes zero. There certainly is resistance still present, but you're not now measuring it on the ventilator. So this was zero by means of no spontaneous breathing, and then this becomes zero, in which case the alveolar pressure then reflects the elastance of the respiratory system multiplied by the tidal volume. More the tidal volume, more will be the alveolar pressure. More is the elastance, which is poor is the compliance. More will be the alveolar pressure. This makes sense. Okay. Now let's go to this slide. This is trying to make it more clinically relevant. That was more physiologic, but this is how it will be at the bedside on the ventilator. That in a volume controlled breath, this is the pressure waveform. The pressure instantaneously increases, and then as the flow is static, the pressure has a steeper, less steep curve. It achieves peak pressure. And when the flow is set to zero inside each breath, that means you set up a inspiratory flow limitation or zero flow condition for about 0.2 or 0.3 seconds, the pressure will drop and become static. This drop in pressure is the resistive pressure, and the pressure from this point till baseline is the elastic pressure. This place is alveolar pressure, and this is the ventilator peak pressure. This is how the alveolar pressure behaves, as we saw in the previous example. So in this slide, you can see this is a very good paper where respiratory mechanics have been reviewed in detail on how to do it and what to make sense of it on the ventilator during ARDS. This is an end expiratory occlusion in the PEEP, total PEEP, but there is an inspiratory pause of 0.3 seconds. You can see here when the flow goes zero. When the flow is zero, it is that time that the pressure measured on the airway is equal to alveolar pressure, and that is what is important. This becomes the plateau pressure. As you do the pause a little longer, then this pressure starts to drop. This would mean that your resistive pressure is probably increased, you feel. But is that true? What does it mean? In the first situation, where you have a 0.3 second of inspiratory pause attached in each breath, like set up in each breath, then that is the plateau which will determine the peak alveolar pressure breath to breath, and which is what is going to determine how the lung is distending or getting injured. This is more important. So a shorter initial part of the pressure is more important, because that helps you to estimate what the maximum problem in the alveoli will be. If you keep it longer, then the plateau may be the peak alveolar pressure, or because the viscoelasticity of the lung becomes equalized, the peak alveolar pressure will drop, or because there may be a pendulum, in the sense the air moves from above downwards from some portion to the other portion, or if there is leak, or if there is inhomogeneity, then the peak alveolar pressure will start to drop. This peak alveolar pressure probably does not reflect the true breath to breath maximum distension that the alveoli will see, at least in some portions of the lung. So if you do it longer and you measure it much later, you are likely to underestimate plateau or underestimate peak alveolar pressure. So try to do it within the breath. That's how it becomes a good pulmonary function test. Okay. So pausing during an inspiration itself in a volume control breath is like a pulmonary function test. It helps you separate, the resistive pressure from the elastic pressure. The elastic pressure is what we now call as the driving pressure, which is plateau minus peak is the driving pressure. Why we call it as a driving pressure? Because it is the pressure which is driving the tidal volume inside the lung, inside the alveoli after the airways, right? Whereas this pressure, resistive pressure, is the pressure which is moving the gas from the endotracheal tube, wherever it is measured, until the end of airways. Okay. And now we know that compliance is equal to tidal volume divided by plateau minus peak, which is the elastic pressure, which is driving pressure. So if you know the elastic pressure, certainly you know the tidal volume, you now know the compliance, and you know the resistive pressure, and you can also know the resistance. So from one particular maneuver attached inside each breath, you get so much information. You get information about the resistance, about the compliance, and the driving pressure, all valuable information, and the peak alveolar pressure. So far so good. Any questions on volume control? Hello? You should ask questions, huh? Maybe this is too basic for some of you who are already into second year and stuff and have already seen it, but I thought we'll do it for those who are starting off or something like that. Now let us look at pressure control cycle. What happens in pressure control cycle? What you do in a pressure control cycle is fix the airway pressure and the I time. The flow and the tidal volume get determined, which makes sense. If you set the pressure difference higher, more will be the flow and more will be the tidal volume. If the pressure is at a particular, if the pressure difference is same, but if you keep it for a longer period, then the flow will be going in for a longer period. If the flow goes in for a longer period, we know that the tidal volume will increase. For instance, look at this. In this situation, as the airway pressure increases, the flow will increase instantaneously. As the peak airway pressure is achieved, the peak flow is also achieved at the same point. And then as the pressure becomes static at the inspiratory pressure that you've set for the inspiratory time, the flow starts to decrease. We'll see why that is. With the increase in airway pressure, increase in flow, the tidal volume starts getting inside. As the tidal volume goes in, the alveolar pressure also increases. The difference between the airway pressure and the alveolar pressure is the determinant of the inspiratory flow. In this situation here, the difference at the start of inspiration is 0, the flow is 0. Then the airway pressure instantaneously increases, but the alveolar pressure is not going to instantaneously increase. So the difference right at the beginning, right after the start of inspiration, is huge. The peak inspiratory flow is huge. As the pressure stays stable and the alveolar pressure continues to increase, the gap between the peak airway pressure and the alveolar pressure keeps decreasing. This difference in alveolar pressure gradient, which continues to reduce, reduces the flow. And then at the end of inspiration, the flow abruptly cycles out and you get into an expiratory flow. Similarly, as we said before, the alveolar pressure and the tidal volume curve is similar. As the alveolar pressure increases, the tidal volume will increase, and as the alveolar pressure comes down, the tidal volume will come down. In the expiratory phase, as the pressure system gets depressurized, when you set an inspiratory time or cycling here, that means the expiratory valve opens, the inspiratory valve closes, the system gets depressurized. As the system gets depressurized, the gradient between the alveoli and the airway is reversed. Now the pressure is more in the alveoli and less in the airways, and so the flow reverses and you have an expiratory flow. Right? Now, what will happen if you keep prolonging the I time without changing the peak inspiratory pressure? As you increase the I time, there is more gas. So for the inspiratory pressure now stays for a longer period, as a result of which the flow which got abruptly stopped here will continue to go inside. This is still a part of inspiratory flow. The peak flow reduces, but the flow is still inwards because the alveoli is still filling up, because you've still given, the system is pressurized. That means the gas is still moving forward until the point where the alveoli cannot take the gas anymore or has achieved the same pressure as the airway pressure, as in this case. When alveolar pressure and the airway pressure become same, you will see that flow becomes zero because there is no flow now. Again, when the flow becomes zero, it is that time when the airway pressure and the alveolar pressure is same. It is that portion here which is nothing but the plateau pressure. So the plateau pressure in a pressure control mode, people believe that is the same as the peak pressure. No, until and unless in that cycle you see the flow coming down to zero. If in that cycle your flow does not come down to zero, then the peak airway pressure is not equal to plateau pressure or alveolar pressure, as you can see it in this case, in this schematic. So for the same difference in airway pressure, if you increase the I time, then the flow gradient continues to be present in the pressure. The pressure gradient continues to be present, and the flow continues to go in. More and more tidal volume is achieved until a point where there is no further flow. There will not be more increase in tidal volume, and that zero flow condition, that part is the plateau pressure. Okay, that part is the plateau pressure. Now we do the reverse. We keep the I time same. I time is constant. It is 1 second, but we keep increasing the difference in the airway pressure. In this example, the flow comes down to zero. That means the end of peak airway pressure is close to alveolar pressure. Not exactly, but close. Now, if you don't change the I time, but you change the difference, like the pressure gradient, so you keep increasing the inspiratory pressure, then again, your peak inspiratory flow will increase because the pressure gradient has changed, and the tidal volume will increase. But it will not change the difference between the peak airway pressure and the alveolar pressure, which is very minimal in all three examples. That will remain very, very similar. All right, and that makes sense because the pressurization or the difference between the two pressure is at a similar time point. If you go for example to 1.5 seconds, then for almost 0.5 seconds the alveolar and the airway pressure will be same, and you will have a kind of an inspiratory pause or a flow zero condition in all three situations. This is to elaborate that the peak airway pressure in pressure control is same as alveolar pressure or plateau pressure only if the flow at the end of inspiration it naturally comes to zero. And here again, it's also to illustrate that change in the driving pressure, change in the peak inspiratory pressure will increase the tidal volume, which is simple to understand. Okay. So far so good. Is pressure control okay?
Yes, sir.
Good. Now, so far we saw volume, and pressure control in completely passive conditions. Simple changes, simple measurements. Let's add spontaneous effort onto the mechanical cycle because that is how most of our patients will breathe. So now the P muscle appears. See the P muscle, as the P muscle keeps increasing, this is volume control, as you can see from square waveform of the flow, and because it's a volume control, the tidal volume is constant. This is the same breath cycle. The flow is also constant, but with each breath, the muscle pressure is increasing because the patient is breathing harder. What will you see? You will see that the pressure waveform shows a scoop out. This scoop out is proportionate to the amount of negative pressure generated by the muscle. So the peak airway pressure does not change too much, will change eventually if the muscle pressure becomes too much, but peak airway pressure probably doesn't change too much, but it starts getting scooped out, and the flow remains constant because that is what you set on a volume control ventilation, and the tidal volume gets constant. This is because part of the flow and part of the tidal volume got delivered because of the patient's negative pressure. So the ventilator has to drop the pressure. The pressure will the system will depressurize. Okay, what will this do? The benefit is that you have a tidal volume which is assured. However, as you increase the patient's effort, if the patient is breathing harder on volume control, one will create flow asynchrony, because this means the flow that you've set is not enough for the patient. Patient is breathing much more negative and actually needs a higher flow to breathe. But because you've set the flow well, it cannot change. It generates flow asynchrony. The demand and the supply are asynchronous. It may also generate something called as pendulum. So air, because the gas does not move from the ventilator to the patient, the gas will move from one region of the lung to the other region of the lung, wherever there is a stronger pull, which is generally in the back. This would mean more gas shifting, and probably if it is significant, it can be injurious to the lung. Opposite to that, for the same kind of setting on the ventilator, if you increase the muscle pressure, as in negative pressure by the muscle force, then in a pressure control breathing, because you've set the pressure control will not change. It is what the ventilator will continue to do mechanically. But the flow, which was less here, will become better, in the sense the peak inspiratory flow will not change too much, but the flow will stay much more broader. It will not drop out very fast. There will not be a zero flow condition, and the tidal volume will keep increasing. The reason is that A, there is a pressure from the ventilator, and B, there is a pressure from the patient. So the total negative pressure or total pressure gradient has increased. As the total pressure gradient increases, you can see the difference between this and this is higher than here, than here. The result of that is that more and more tidal volume gets in. All right. What is the benefit? The patient is comfortable because patient needs more flow, and patient is getting more flow, and patient getting more tidal volume. But if it is not suitable for the patient, then it may cause an overinflation injury. You can appreciate that. You might have set up this pressure control to give you initially a tidal volume of about 6 ml per kilo, but if patient generates a negative pressure of, say, if this was a driving pressure of 15 and a patient generates a negative pressure of 10, now the driving pressure is truly 25, then your tidal volume can go from 6 to almost 9 or 10 ml per kilo, which may become overinflation. All right. So this is to say, when they interact, they can have a beneficial effect of what you need, or depending on the effort, the amount of effort, they can have an opposite problem. As a result, if you want a patient to have a definitive assured tidal volume, you may want to control the negative pressure generated by the patient's muscle effort while on volume control, so deeply sedated or paralyzed, etc. But once the patient is out of the red hot ARDS phase in the first week, and then you want the patient to be comfortable and use less sedation, then go to pressure control, let them breathe themselves and determine their own tidal volumes. That kind of clinical application is the purport here. So far, so good?
Yes, sir.
Great. Now let's go to pressure support cycle. Are we good to go ahead, or should we stop here for today?
I think it's better also because not many people are there.
Okay, you want to stop?
It's your wish, sir. If you want to continue, it's okay.
I think we are very close. Let's just do this pressure support and then we'll take it from there, okay?
Sure.
Now, what is pressure support? In pressure support cycle is not truly very different from pressure control. Of course it is different, but not truly. What happens is you set a support value, and what you set is the inspiratory flow termination, which is set as a percent of peak inspiratory flow. Usually it is 25%. 25% would mean that when the peak inspiratory flow is 25% of the peak inspiratory flow, that means it has achieved its 1/4 value from the maximum, the system will automatically cycle into expiration. And there is a pressure support that you set to about 8 or 10 or whatever. The trigger is always the patient. So patient triggers the cycle ventilator. And this cycling is also kind of determined by the patient is the argument here, because as the patient breathes in, the negative pressure generated will generate more flow. Higher the peak flow generated by that negative pressure, more different will be the value here, which would mean that the cycling will depend upon the peak inspiratory flow. If the peak inspiratory flow is lower, then the cycling will be at a lower flow. If the peak inspiratory flow is higher, the cycling will be at a higher flow. So because the peak inspiratory flow is determined by patient effort, the cycling is said to have been determined by patient effort. However, the caution here is that if you set a pressure support significantly high that it will suppress patient's effort to be strong enough, then it actually behaves like pressure control ventilation, and it does not have many significant advantage. But it is a very good spontaneous mode, as such available in all patient ventilators. So if you want the patient to do all the work, all you need to go to pressure support, let the patient breathe, and gradually reduce the pressure support as much as possible, so that you can see patient's native work of breathing on that CPAP level. Okay. Now in this example, we see that as the negative pressure from the patient increases despite the same pressure support and despite the same 25% flow cycling limitation, you see a change in flow, but the tidal volume is near about the same because the pressure support is kept unchanged. The inspiratory time part is also not changed because it is based, but you have changed the flow cycling. 25% is 35% is 35% of this, so the expiration happens earlier, and 45% is 45% of peak flow, so the expiration happens even earlier, which would mean for the same pressure support, the tidal volume will keep reducing. Okay, so this is the point to remember of how tidal volume and inspiratory cycling and patient effort will relate during pressure control and pressure support ventilation. All of this comes to 5 fundamental modes, and this is what one needs to know as basic modes. The rest of the things are derivations of it. The rest of the things are combinations of those. Those are not modes. Modes are these 5 fundamental things. One we said is a volume control, which is where it's completely mechanical. You set the flow and you set the tidal volume. The machine triggers the breath depending on when the flow is cycled off and flow is cycling in. And the patient's resistance and compliance will determine what the airway pressure will look like. In the sense, for the same tidal volume, if the compliance is poor, then the airway pressure will be higher. For the same tidal volume, if the compliance is better, then the airway pressure will be lower. But this is what you set. You set the flow, you set the tidal volume. What is volume assist? This is the second fundamental mode where you let the patient trigger the ventilator. So patient generates a negative breath. There is a pressure sensing. This triggering, there will be pressure, flow, etc. We will see that in the next class. But basically the point here is that an assist control mode is where the breath is absolutely similar like a control mode, which is like a mandatory breath, but patient triggers the breath. That's the only difference. Similarly, in pressure control, you set the pressure and the flow and tidal volume are determined based on the patient's resistance and compliance. It is again machine triggered when it is pure pressure control, and it is patient triggered when it is pressure assist control. The pressure support breath is patient triggered and in some way patient cycled depending upon the set minimal flow that you've kept. So when patient cycles the breath off as well, that is the moment you call it as a spontaneous breath. It is not based on the trigger. So even if the patient triggers the breath, these would be still called as assist control, which would mean the breath pattern is like a mandatory breath. But when patient cycles the breath, then the breath becomes more spontaneous. The catch here is, depending on how have you set the minimal flow and what kind of patient effort there is, the pressure support can almost behave like pressure assist control where the patient triggers, but by patient triggers and ventilator pressure takes over, and then the cycling is just by the value. It's not really determined by the patient. So it may, if the pressure support value is very high and you set the flow very low, then it may not be as much of a patient determined cycling. Just need to be watchful of that. So this becomes more spontaneous and these become more mandatory modes of breath. There is a breath sequence and then there is a breath type. Breath type and breath sequence we will see in the next class, but these are 5 fundamental modes. That is what one needs to understand basically. When you understand these 5, read about it, think through it, then everything else will make sense. This is a little bit of homework for all of you. Figure out in this what is a control of inspiratory flow in volume, pressure and pressure support. What is a set variable? What are the types of cycles that you see? What is the trigger? What is the cycling variable? And what is the control of I time in each of this? If you want, I'll send you the slide later if you're interested in solving this. This table will help you sort out quite a lot of things in your head. And then how can we measure plateau pressure in pressure support mode? Is it possible? This is something that you should figure out. Okay. Here are some of the references that you should go through, which will help. And all right, thank you.
Thank you, sir. Wonderful class, but unfortunately, not many people could join. So
okay.
Next time we will make sure.
Okay.
Okay, sir.
Okay.
Thanks a lot.
Okay. Bye.